They traverse the length of the facial canal in the temporal bone, but note what happens by the time the facial nerve reaches the stylomastoid foramen. By this point, two of the functional components of the facial nerve have left the facial nerve, leaving only lower motor neurons that innervate muscles of mastication and some sensory fibers that innervate skin over the mastoid process and around the ear to exit from the stylomastoid foramen. Both the parasympathetic axons and the taste fibers have left the facial nerve by branching off at different points through the facial canal prior to the emergence of the nerve itself through the stylomastoid foramen. So let's deal with these branches in some detail just in terms of what their functions are. The major skeletal muscle function of the facial nerve is to innervate muscles of facial expression, muscles that change the shape of openings on the face. And those name branches are the temporal, zygomatic, buccal, mandibular, and cervical, as illustrated here. And their job is to innervate muscles that basically shut the eye, wrinkle the forehead, change the shape of the nose, and purse the lips, change the shape of the mouth, and wiggle the ears if you're so blessed. So now, the sensory fibers that are emerging from the stylomastoid foramen are those that basically innervate skin in and around the ear, including skin over the mastoid process. So now, proximal to that, two well-known nerves basically exit from the facial in the temporal bone. One of them is the chorda tympani. You can see it illustrated branching off the facial just proximal to the stylomastoid foramen. The chorda tympani conveys sensory fibers of taste from the anterior two-thirds of the tongue, as well as carries preganglionic parasympathetics that synapse in the submandibular ganglion that facilitate the secretory activity of the submandibular and sublingual glands, respectively. Next, just above that, you can see that the only non-muscle of facial expression, other than the digastric and the stylohyoid muscle that's innervated by facial nerve fibers, is the stapedius muscle. And the nerve to the stapedius exits from the facial nerve, enters the middle ear, and obviously reaches the stapedius muscle that is limiting movements of the ossicles by attaching to the stapes in that middle ear. And then the first branch that arises from the level of the geniculate ganglion that houses the cell bodies of all of the sensory fibers in the facial nerve is the greater petrosal. It, like the chorda tympani, conveys taste fibers, in this case from soft palate, as well as conveys preganglionic parasympathetics to the pterygopalatine ganglion that basically facilitate the secretory activity of oral and nasal mucus glands, and significantly for clinical purposes provides the innervation to the lacrimal gland that's illustrated at the upper right of this diagram. So now, let's kind of summarize the functions of the facial nerve on the next slide, and they are listed here as well. Certainly the major motor function of the facial nerve is to innervate muscles of facial expression, as illustrated here, and including some muscles that are acting on the hyoid bone respectively, as well as the stapedius. So, in addition, certainly the parasympathetic motor functions of 5 are to facilitate the secretory activity of the submandibular and sublingual glands and to increase lacrimation at the level of the lacrimal gland. And the major sensory fibers, in addition to those providing or innervating skin behind the ear, are to facilitate or innervate taste receptors in the anterior two-thirds of the tongue and the palate. So in terms of clinical perspective, basically a common phenomenon of a patient that develops a peripheral facial nerve lesion or a central facial nerve lesion will be Bell's palsy, where the patient will have a degree of weakness of muscles innervated by facial nerve fibers. And this manifests itself most clearly as the corner of the mouth droops, the patient will be unable to close their eye, wrinkle their forehead on the corresponding side. They may also have hyperacusis, as we'll see, altered sensation, as well as some other parasympathetic deficits, and they're illustrated, will be illustrated subsequently. So now, on this page is the same diagram again, but it illustrates 4 different lesion locations that basically would give you a different range of signs and symptoms attributable to a facial nerve lesion. If the lesion were at number 1, the patient would have weakness of muscles of facial expression and probably pain behind the ear. If the lesion is proximal to the chorda tympani, taste and parasympathetic function, lacrimal or submandibular and sublingual gland function will be affected. If the lesion is proximal to the branch point of the nerve to the stapedius at number 3, there's going to be hyperacusis, increased sensitivity to loud sounds. And if there were a complete lesion of the facial nerve, it would include all of those sensory and motor signs: facial weakness, pain behind the ear, altered taste sensation, hyperacusis, plus a loss of lacrimation. And obviously loss of lacrimation would arise from a lesion that's proximal to the branch point of the superior petrosal, of the greater petrosal nerve. So in summary, on the next slide, we can see that specifically when you lesion the facial nerve virtually anywhere, basically you're going to get these signs and symptoms illustrated in number 1, ipsilateral facial muscle weakness and pain behind the ear, and you're going to lose the motor limb of the corneal blink reflex, because those are the fibers of the facial nerve that have the longest peripheral course, extending all the way from the internal auditory meatus to the stylomastoid foramen. And then as you move proximally, the closer you get to the brainstem, you will add signs and symptoms. If the lesion is proximal to the branch point of the chorda tympani, you will alter taste from the anterior 2/3 of the tongue. Probably a reduction in salivary gland secretion is not diagnostically significant. If the lesion is proximal to the branch point of the nerve to the stapedius, hyperacusis will be the result. And finally, a complete facial nerve lesion will include the signs and symptoms at 1, 2, and 3, but will also include loss of lacrimation, which is the most diagnostically significant sign associated with a facial nerve parasympathetic lesion, and that patient will basically present with an eye that is dry and red. We've now summarized basically what might occur in terms of signs and symptoms if a patient has a complete lesion of the facial nerve, either outside the brainstem, somewhere in its course through the temporal bone, and or inside the brainstem. And we want to play on this point by using this slide again, by illustrating that when a patient has facial muscle weakness that basically is caused by a lesion of the facial nerve, since the facial nerve simply contains lower motor neurons, no different than lower motor neurons that we've described everywhere else, all of the facial muscle weakness is certainly going to be ipsilateral, as illustrated under number 1. But we need to make a very important distinction about that by going back and illustrating, yes, there are lower motor neurons in not only cranial nerves as well as spinal nerves, but we need to illustrate how those lower motor neurons in cranial nerves get their upper motor neuron innervation, and how the differences in that upper motor neuron innervation are going to be clinically significant. For example, going back to spinal nerves, and we discussed this when we talked about the spinal cord, and this is just a reminder, and that is, how would we describe the upper motor neuron innervation of all lower motor neurons in spinal nerves? Well, it's illustrated on this chart, and you can see again the upper motor neuron cell bodies in this example are arising from the right motor cortex, and basically they all cross the midline, and they synapse on lower motor neuron cell bodies that are in the left side of the spinal cord. So we make the point over there on the right side, on the left side of the image, that the upper motor neuron of innervation of lower motor neurons in spinal nerves is virtually all contralateral by axons of the corticospinal tract. But now, using the diagram in the next picture, we need to make a fundamental distinction about how cranial nerve lower motor neurons get their upper motor neuron innervation. So now, first, terminology. We call the axons of the upper motor neurons that innervate lower motor neurons in spinal nerves corticospinal fibers. We call the axons of upper motor neurons that innervate lower motor neurons in cranial nerves, we call those axons corticobulbar axons. The term bulb refers to brainstem. So these are axons of upper motor neurons that arise from cell bodies in motor cortex and basically innervate lower motor neurons found in cranial nerves. But here's the fundamental difference as illustrated by the text to the left of this figure. The upper motor neuron innervation of most lower motor neurons in cranial nerves is bilateral, not contralateral. That means if we have an isolated lesion in either the corticobulbar fibers on the right or the left, there's probably not going to be any significant cranial nerve deficits because those same lower motor neurons are driven by the opposite or intact hemisphere. However, as illustrated by this figure, the upper motor neuron innervation of lower motor neurons in the facial nerve is an exception. And here's the point. Only some of the lower motor neurons in the facial nerve are bilaterally innervated. The other lower motor neurons in the facial nerve are contralaterally innervated. So let's look at the difference. Over on the right side of this diagram, you can see the left facial nerve. And the left facial nerve is going out to innervate all of the muscles of facial expression on the left half of the face. And basically we've kind of divided them into two little portions because of their difference in innervation. The upper face, we use the term division, basically goes out and innervates muscles that wrinkle the forehead and shut the eye. The lower motor neurons that go to the lower face basically innervate muscles around the nose and the mouth, changing the shape of the nares and allowing you to purse your lips, keep your lips closed, etc. But here's the difference in upper motor neuron innervation. It turns out that only the upper motor neurons that innervate muscles that wrinkle the forehead and shut the eye are getting a bilateral upper motor neuron corticobulbar innervation. And in this picture, you can see axons coming from upper motor neuron cell bodies in both the left motor cortex and the right motor cortex are simultaneously reaching those lower motor neurons in the facial nerve that go to the forehead and shut the eye. In contrast, the lower motor neurons that innervate muscles of facial expression around the nose and the mouth are innervated like spinal nerve lower motor neurons, only arising from axons in the contralateral motor cortex. So since we're looking at the left facial nerve, you can see that the axons of the left facial nerve to the lower part of the face, innervating muscles around the left side of the nose and the left side of the mouth, are being driven only by upper motor neurons whose cell bodies are in the right hemisphere. So here's the distinction. What will be the difference in a patient that has a lesion at A to all of the corticobulbar fibers coming out of the right hemisphere versus a lesion in a patient at B to the left facial nerve? So let's do A first. Let's suppose we wipe out in a patient with a stroke that involves motor cortex, let's say. We lesion all of the corticobulbar fibers arising from the right hemisphere. The question is, will there be any cranial nerve deficits? And the answer is no, because virtually all of the cranial nerve lower motor neurons are bilaterally innervated and will still be driven by the intact left motor cortex. The only weakness that will be seen, as illustrated over on the left side of the page, if you lesion A to the right corticobulbar fibers, there will be only a weakness in the contralateral, or in this case, the left lower face. The patient's ability to shut their eye and wrinkle their forehead will be intact bilaterally. In contrast, if a patient has a complete lesion at B, which is certainly in this case to the left facial nerve, these are lower motor neurons, now what will the extent of the facial weakness be? The lesion B to the left facial nerve, as in Bell's palsy, as we indicate, will result in a complete ipsilateral, in this case, left face weakness, where the patient will not be able to basically wrinkle their forehead, shut the eye. There'll be an absence of the motor limb of the blink reflex on the side of the lesion, will not be able to flare their nostrils, and basically may have saliva dripping out of the corner of the mouth because of an inability to purse the lips. So remember the differential. Patients that have a facial nerve lesion are going to have a complete ipsilateral facial weakness, resulting in a weakness in the ability to wrinkle the forehead, shut the eye, flare the nostrils, smile, frown, and so on and so forth. In contrast, a patient with a corticobulbar lesion, typically above the area of the facial nucleus and the pons, is going to have no effect on other cranial nerves, and the only pronounced effect will only be a contralateral lower face weakness. As in our example, we lesioned all the corticobulbar fibers at A coming out of the right hemisphere. It resulted in only a lower face weakness on the left side of the lower face. So bear in mind that differential because it might come up when we deal with brainstem lesions that are inside the brainstem or above, affecting those corticobulbar fibers. So now, let's move on to the last two of the mixed cranial nerves. First of those is illustrated on this page. This is a diagram of cranial nerve 9, the glossopharyngeal nerve. It looks complicated in terms of the number of fibers that it contains, but in terms of its functional and clinically significant anatomy, it's very straightforward. For example, all of the axons, sensory and motor, of the glossopharyngeal nerve exit from the cranial cavity by way of the jugular foramen, as illustrated here. So now, in terms of motor function, the lower motor neurons in the glossopharyngeal nerve innervate a single muscle, the stylopharyngeus muscle that you see illustrated on this diagram. Note where the lower motor neuron cell bodies are found in the medulla, because we know that the point of exit of the ninth nerve is from the medulla. They arise from the nucleus ambiguus that's found basically at upper medulla levels. So now there's a single skeletal muscle innervated by cranial nerve 9 that is not diagnostically significant. It merely acts as an accessory longitudinal muscle that elevates the pharynx that cannot be isolated and tested clinically. So I can't use the integrity of the motor fibers to the stylopharyngeus muscle as a reliable indicator of ninth nerve function. So now, the other motor fibers of 9 are parasympathetic, and they're shown by the blue lines. The cell bodies of those preganglionic parasympathetic neurons arise from the inferior salivatory nucleus, and basically they leave through the jugular foramen. They're going to find their way through a circuitous route to synapse in the otic ganglion. Their goal is to participate in the secretomotor innervation of the parotid gland. But again, if I have a complete lesion of the ninth nerve that affects the parasympathetic fibers to the parotid gland, that's probably not diagnostically relevant because I certainly have other salivary glands contributing to the content and volume of saliva. So the point is, the motor neurons in the glossopharyngeal nerve are illustrated by solid lines. I can't use any of the motor fibers as a diagnostic indicator of ninth nerve integrity. Fortunately, the ninth nerve has lots of sensory fibers. The most significant of them, shown in dashed lines, are basically providing general sensation from the oropharynx, particularly the pharyngeal mucosa in the range of a tongue depressor, and also provide innervation to the mucosa of the posterior one-third of the tongue for both general sensation and taste, also in the range of a tongue depressor. It is those sensory fibers that, when stimulated, provide the only real reliable diagnostic indicator of ninth nerve integrity. So now, in addition, there are sensory fibers of 9 that innervate the carotid sinus and the carotid body, participating in visceral reflexes that help the body respond to changes in blood pressure and the chemical content of blood. And there are sensory fibers in 9 that also innervate the mucosa of the middle ear. But again, we can't reliably test those fibers diagnostically. So let's summarize the ninth nerve on a chart on the next page. Yes, it's certainly mixed. And again, down at the bottom of this chart, you can see that the skeletal motor fibers innervate a single muscle that's not diagnostically significant. The parasympathetic axons increase the volume and content of saliva by providing a secretomotor innervation to the parotid gland, again, not diagnostically significant. So basically, the only way we can evaluate ninth nerve integrity is to stimulate its sensory fibers from the oropharynx and from the posterior one-third of the tongue. And in doing so, we are utilizing another set of motor and sensory cranial nerves in our third of our cranial nerve reflexes, the gag reflex. So basically, the gag reflex utilizes sensory fibers, mucosal sensory fibers of 9 from the oropharynx and posterior tongue. They link together bilaterally with lower motor neurons in the vagus nerve. So basically what happens is when you stimulate the sensory fibers of 9 on one side, there is bilateral stimulus of all of the skeletal muscles innervated by cranial nerve 10. And they include virtually all the muscles of the palate virtually all the muscles of the pharynx, and definitely all the muscles of the larynx. All of those muscles are going to be activated as a way of artificially stimulating the second or involuntary phase of swallowing, the so-called gag reflex. So there's really just a loss of that sensory limb of the gag reflex involving sensory fibers of 9. That's the only reliable diagnostic way of determining ninth nerve integrity. So now, let's look at cranial nerve 10, which is going to be the motor limb of our gag reflex. And fortunately, as we indicated, there are lots of reliably diagnostically significant motor fibers of cranial nerve 10. So now, cranial nerve 10 fundamentally has a couple of significant pharyngeal or laryngeal branches that carry those motor fibers to skeletal muscles of the palate, the pharynx, and the larynx. For example, the branches of the vagus nerve that form the so-called pharyngeal plexus innervate virtually all the muscles of the palate, virtually all the muscles of the pharynx, both constrictors and elevators. The laryngeal nerves are the superior laryngeal and the recurrent laryngeal. They are carrying motor fibers that innervate the cricothyroid muscle in the case of the external branch of the superior laryngeal nerve. All of the other muscles of the larynx are innervated by branches of the recurrent laryngeal nerve. So now, all of the fibers of the vagus nerve traverse the jugular foramen like those of 9 and 11 as well. Motor fibers are the most clinically significant ones. There are lots of sensory fibers in the vagus nerve, but we don't really pay attention to them too much diagnostically. They provide general sensation from areas of the laryngopharynx, from areas of the larynx, as well as providing general sensation from thoracic and much of the abdominal visceral structures. And there's a major parasympathetic component of the vagus nerve, as was discussed in gross anatomy. Those parasympathetic synapse and terminal ganglia enter near the wall of a visceral structure being innervated and provide the innervation to glands, smooth muscle, and to the heart in the thorax, as well as in most of the abdomen. But again, the diagnostically significant fibers of the vagus nerve are those that are going to innervate muscles of the palate, the pharynx, and the larynx. So let's be specific about those. They're listed on the chart on the next page. The vagus nerve innervates virtually all the muscles of the palate except for the tensor, all the muscles of the pharynx except for the stylopharyngeus, which we saw was innervated by 9. So certainly in a patient with a complete vagus nerve lesion, there's going to be weak